Greetings once again. Our attention here is going to turn to the third trimester visit. Now, as always, I want to preface this, but particularly here, that this is for medical educational purposes only. I know that there are a lot of people that watch my videos that are patients that are trying to self-diagnose, and while I believe it's always important for patients to be well educated, this is never, all the information that I give is never to substitute the advice from your own physician. So please take this with a grain of salt, bearing that in mind. Okay, so as all these trimesters we've been talking about, there's generally more than one visit. Visits should be monthly up until 28 weeks, then they should be bi-monthly until 36 weeks, and then weekly after 36 weeks. So during all three trimesters, there's going to be more than one visit. So I just put visit in the singular here, but bear in mind, of course, that there are going to be more than one visit during pregnancy during each trimester. Okay, so this is sort of an overview of all the things that are done. Don't memorize this. This is just what I found in an OBGYN textbook. But these are some of the things that are done and when they should be done according to these authors. We'll go over the purpose of the visits during the third trimester. We'll talk about some of the labs that are done, some different ones here that we don't see elsewhere. And then I do want to talk in some detail about the GDM testing because this is more of a battery of tests rather than a single test. And then some of the common events and patient education. We're not going to talk about the management of any of these things should we diagnose them. So should we diagnose gestational diabetes, how we manage that? We're not going to talk about that here. We're going to discuss that in a future talk because this is, for our purposes here, we're talking about normal pregnancy. Okay? So this whole trimester system is really, it's not important as far as what's happening during the pregnancy. So there's nothing magical that happens between the first and second trimester. Once you hit the second trimester, there's nothing going on that really delineates the fact that, okay, now we're in a new trimester. This is just a way of, it is really just a means of nomenclature. It's completely arbitrary. And some people, when they define trimesters, they will take, okay, it's a 40, pregnancy is typically a 40-week event. Normal delivery happens around 40 weeks, so we're going to divide 40 by 3, and we'll round that off to 13 weeks per trimester. So we go from 0 to 13, 14 to 26, and 27 to 40, giving that extra week to the third trimester. Others will say, well, pregnancy can last up to 42 weeks, and so we'll divide it into 14s. It really doesn't matter the way you do it. Okay, so you'll see some sources saying it starts at 26, others you'll see it saying it starts at 28. Doesn't really matter. Okay, it really doesn't matter. For the most part, the same weeks are going to fall into the trimesters regardless of what method you use. So for our purposes, the third trimester of pregnancy extends from the beginning of the 28th week until the end of pregnancy. Because at this point the fetus is viable at 28 weeks and even before that, the tests during the third trimester are mainly focused on safeguarding the mother and the fetus's health and preventing any foreseeable complications, namely those complications which can arise out of gestational diabetes, complications that can arise out of being colonized by group B strep. That's what we're mostly looking at during the third trimester screens. So the purpose of the third trimester visits are to monitor fetal growth. Remember that the fetus is growing faster than ever during the third trimester. And by faster than ever, I don't really mean rate so much as I mean the raw weight that they are growing. So as far as in terms of ounces, they're growing faster than ever during the third trimester. We also want to monitor the fetus's position. This becomes important as we get into the final weeks of the pregnancy. The fetus is much less likely to move around and change positions the later you get in the pregnancy just because of size constraints. and then also the fetus's well-being. So as far as well-being, we're talking about fetal heart tones. You can start monitoring fetal heart tones at 10 weeks. You can use a Doppler, and you will really do that at every visit. It doesn't tell us a whole lot, provided that the fetal heart rate is normal. Other than that, it doesn't really tell us much. You can measure the fundal height. Now, you aren't really going to get a whole lot of information until you hit around 16 weeks, and even then, measuring the fundal height doesn't tell you a whole lot. If it's off by a centimeter in either direction, it doesn't really, it's not really informative. So we're looking really here for major discrepancies in the fundal height. At about 16 weeks, starting at 16 weeks, the fundal height should be in centimeters, approximately the same as her number of weeks gestation. Starting at 36 weeks, we start to do Leopold maneuvers. These aren't done as much as they used to be because we do ultrasounds all the time, but the Leopold maneuvers historically have helped us determine what the fetal lie is. So is the fetus breech, or is it in a cephalic presentation? And then there's some advanced tests that are done more commonly now, but they are still not routine tests, and they probably will never be routine tests, but they are done frequently because there are a lot of pregnancies that have complications. So non-stress test is something that you'll see done a lot, and then the biophysical profile, and the non-stress test is actually part of the biophysical profile. So the biophysical profile is really just a more elaborate prenatal test. We also monitor for maternal complications. So during the third trimester and towards the end of the second trimester, one of the big complications is gestational hypertension, and namely preeclampsia. During the third trimester, the maternal blood pressure should never exceed 120/80. And we're talking about a resting blood pressure. It should not go above 120/80. Remember, 120/80 is perfectly normal in non-pregnant people, and you can even go higher than that. Up to 139 systolic resting blood pressure would be considered in the normal realm. In the pregnant woman, if it's above 120/80, it raises a red flag. Now, if it's significantly elevated, and here we're talking about systolic pressure over 140 or diastolic pressure over 90, this is suggestive of preeclampsia. And we would really need to get this twice over a course of greater than 4 hours in order to really point towards preeclampsia. But if the blood pressure is elevated, that is highly suggestive of preeclampsia. And this is one of the more common complications of pregnancy after 20 weeks. Gestational diabetes is another complication, particularly here in the US, where mothers have a lot of risk factors for gestational diabetes. In the US, mothers tend to be a little bit older when they're pregnant compared to in lesser developed countries. They also tend to be more overweight than in other countries in general because we are a fat country. So technically, we only need to do screens on women who have a risk factor for gestational diabetes, but some 90% of women who are pregnant in this country have risk factors. So we just do diabetes screens for everybody, and we do this at about 24 to 28 weeks. So this will be part of your routine prenatal testing. We also retest for gestational anemia. We did that earlier on, but we have to do it again at the beginning of the third trimester, and the reason for that is because as the pregnancy progresses, the fetal demand for iron increases. And so if a woman was sort of borderline gestational anemia, but wasn't anemic, as she progresses later on into the pregnancy, she may become anemic, in which case we would need to further her supplementation of iron. We also detect issues that may alter the management of labor and delivery. One of the big things here is Group B strep culture screening, and that is done at 36 weeks. Now, earlier on, we did urinalysis and culture, and if that culture ever came back positive for Group B strep, then we consider her colonized with Group B strep. And we really don't need to do this 36-week GBS culture because we consider her already colonized, and we're going to treat her with penicillin during labor and delivery. But if her urine test did not come back, if the urine culture did not come back positive for group B strep, then here we're going to get swabs of her lower vagina and perianal area, and then see if that comes back positive. So this is not necessary if her urine culture came back positive for group B strep. Otherwise, we get the swab of the lower vagina, perianal area, and if that comes back positive, then we will also treat her for group B strep colonization, and that treatment is not done once it comes back positive. That treatment is administered during labor. And then in certain high-risk patients, we will repeat that STD screening, get gonorrhea, chlamydia, syphilis, HIV. You can do all that again if it's a high-risk patient, namely patients who are very sexually active, etc. Okay, so this is how we do fetal heart tones. Like I said, you can start doing this at about 10 weeks, which you'll be able to hear the fetal heart tones with this Doppler device. All you do is you take a little bit of jelly, place it on the bottom of the transducer, and put it right around her lower umbilical area, and then just kind of manipulate, kind of turn the transducer in place, and eventually you should hear fetal heart tones. Very important to differentiate between the mother's heart tones and the fetal heart tones. They'll sound pretty similar, but the mother's heart tones should be much slower. Fetal heart tones will run between 110 and 150. If mom is resting on the bed here, she shouldn't be that high. She should probably be 60, 70, 80. So that will help you just knowing the rate difference. Another tip for using these transducers: don't move it around mom's belly. That's not really going to help you. All you need to do is place it right in the middle and just kind of turn it in place. Okay, so just you can point it in different directions, but don't move it around mom's belly, because you're not going to get a whole lot out of that. You're just going to wind up with mom's belly full of jelly. So just move it around in place, and eventually you should hit the direction where the fetal heart is in alignment with the ultrasound waves that pick up the heart tones. Okay, so just a little tip there. The non-stress test is done in certain indications in which there are complications that arise during the pregnancy, in which we want to really make sure that baby is doing okay. And so in this instance, what you do is you place one transducer which measures mom's contractions, and then another transducer which measures which measures baby's heart rate. And so you may not get contractions, but what we're really measuring is the heart rate, and we want to see if there is any correlation between the baby's heart rate and any contractions that are present. So this is an example of a non-stress test, and like I said, this is not part of routine care, but this is done in many instances when there are any kind of complications that might arise. So for instance, if she has gestational diabetes, or if she has preeclampsia, we'll do these non-stress tests to make sure baby is doing okay. And so none of these really look like sustained contractions here, but what we want to look for is accelerations. Okay, so non-stress test, we're looking for accelerations. And something is considered an acceleration if the fetal heart rate increases by at least 15 beats per minute for more than 15 seconds. So we consider that, we call that 15 by 15. And so we should see more than 2 accelerations over a period of 20 minutes, and that is considered a reassuring non-stress test. Okay, so here we see 2 accelerations. Okay, so the fetal heart rate, you draw a baseline, we'd say it's probably right around 130 or thereabouts, and here you see an acceleration going up to about 155, we'll say here. And so that is definitely an acceleration of more than 15 beats per minute. And as far as time, it lasts about a minute. Okay, so definitely an acceleration here, and then you see another one here. There should be 2 or more in a period of 20 minutes. Okay, so what are the labs that we do? Well, we want to get a urinalysis, and this is still recommended. There are some organizations, authors that say that it's really not important to get urinalysis anymore. But what we're looking for here is glycosuria, which is a weak indicator of possible gestational diabetes, and proteinuria, which used to be a criteria of preeclampsia, but is not anymore. But some consider it a weak indicator of preeclampsia. So this is done at each visit still. But you may run into some OBGYNs that don't do this anymore. We get a CBC. Here we're looking primarily for gestational anemia. And as I said, because of the increasing fetal iron demand, maternal anemia may develop during the 3rd trimester. A hemoglobin below 10 is considered anemia, and then this is, of course, more than likely an iron deficiency anemia. You can, if you want, follow it up with iron studies, but a lot of people just presume it's iron deficiency anemia, and they'll treat it with iron supplementation. It does bear indicating here that iron supplementation, one of the side effects from it is constipation, and constipation is something that happens for many reasons during pregnancy, partially because you've got a big uterus pressing up against the bowels, and there's all sorts of, that's just one of the more benign things that happens during pregnancy, but iron supplementation itself can cause constipation, so keep that in mind. The oral glucose tolerance tests, which are our screening test, and the other is a confirmatory test for gestational diabetes. This is done 24 to 28 weeks. We'll talk about this in a little bit greater detail later on. The atypical antibody test, this is only done for patients who are Rh negative, but what we're looking for is the presence of atypical antibodies. If she is atypical antibody negative, here we're talking about the anti-D antibodies, then we give her RhoGAM at 28 weeks. If she's atypical antibody positive, then we don't give her RhoGAM. Why? Because it's not going to do anything. RhoGAM prevents you from making atypical antibodies. It doesn't do anything if they're already there. So if she's Rh negative, we get the atypical antibody test at 28 weeks. If she is atypical antibody test negative, if she doesn't have the atypical antibodies, then we give her RhoGAM to prevent her from making antibodies. If she's atypical antibody positive, then we keep that in mind because there's a possibility of complications arising during this pregnancy. And then GBS. As mentioned, we get vaginal and rectal samples, sort of swabbing around the anus and then the lower vagina, and then that is taken and cultured. If she's positive for GBS, then we give her 5 million units of IV penicillin G during labor, starting off, and then after that, every 4 hours until delivery, we will give her about 2 million units of penicillin G. So that is done as prophylaxis. Why do we do this? Because occasionally that group B strep that is in the vaginal tract can get passed on to the neonate, and in rare instances, but enough to where it's concerning, that baby can then become colonized with the group B strep, and then in some of those instances, you can get fetal sepsis and GBS pneumonia. And so we want to prevent those cases, even though they're rare, we want to prevent those cases from happening. And so any mother who is GBS positive, we give her penicillin during labor. If she's penicillin allergic, you can use clindamycin or erythromycin, but penicillin is the drug of choice. And I will make videos later on to talk about these in greater detail. I'm just talking about here why we're doing these things. Okay, so the gestational diabetes testing, we get these oral glucose tolerance tests. And the one that we give to every woman, no matter what, is the 1 hour 50 gram oral glucose tolerance test. So this is a screening test, and this test alone will not diagnose gestational diabetes. Okay, so this is just this liquid that is given to the patient, and they drink it. There's no need to fast beforehand. They drink this liquid, and then after 1 hour, we will then measure her blood glucose. If it's below 140, then that is completely normal, and there is no need to do anything else. If it's above 140, then we need to do further testing. Okay, so if it is above 140, then what we're going to get on her is a fasting blood glucose, and then also a 3-hour 100 gram oral glucose tolerance test. And this is done if we have a positive screening test, and that screening test is the 1 hour 50 gram test. Okay, so first we do an overnight fast, and if her fasting blood glucose comes back at more than 125 milligrams per deciliter, then we consider her to have overt diabetes, not just gestational diabetes, but overt diabetes for our purposes, and there's no need to proceed any further. We're going to treat her as though she has diabetes. If it is below 124 or below, then we do this 3-hour 100 gram oral glucose tolerance test. Okay. So you can have gestational diabetes but have a normal fasting blood glucose. So the 3-hour 100 gram oral glucose tolerance test is really very similar to the 1 hour 50 gram. It just takes a little bit longer. So you give this, again, this oral bolus of glucose, which is in sort of a drink. A lot of mothers will tell you that this tastes terrible. But they drink this this bolus, and then what you'll do is you'll measure her blood glucose at 1 hour after administration, 2 hours after administration, and 3 hours after administration. And in order to diagnose gestational diabetes, you need to have abnormal values on 2 or 3 of these measurements. Okay, so you have 3 measurements, one at 1 hour, one at 2 hours, one at 3 hours. But if you just have an abnormal measurement at one of those points, it's not diagnostic. You have to have it at 2 or 3 of these points. So abnormal is considered at 1 hour more than 180, at 2 hours more than 155, or at 3 hours more than 140. So if only one result is abnormal, the diagnosis is not gestational diabetes, rather it is an impaired glucose tolerance, and we do not treat that like we do gestational diabetes. But if you have 2 or more abnormal points here, then we're going to consider that gestational diabetes, and the first line of treatment is diet and appropriate exercise and home glucose monitoring. Okay, and we will talk about that again at a later lecture. So some of the common events that occur during the 3rd trimester. During the last several weeks of pregnancy, the fetus will move into its presenting position, which we hope is vertex. Okay, we want a non-breech delivery. And that can be detected either via ultrasound or traditionally via the Leopold maneuvers. And I will talk about that just so you have an idea of what that is, because the name doesn't really tell you much. But the Leopold maneuvers are used to determine the fetal lie. Ultrasound can be done at 35 to 36 weeks to confirm the position. And if you have a breech position at 37 to 38 weeks, then you can do external cephalic version. I am not going to talk about that here because that really goes beyond the scope of normal prenatal management. Around 36 to 40 weeks, the fetal head will descend into the pelvis, hopefully, provided we don't have a breech lie. And that is called lightening. It causes this phenomenon of what we call lightening. And the reason we call it lightening is because the mother will be able to breathe easier. It feels lighter. Why does it feel lighter? Because the baby's head moves down, and so does the rest of the baby's body. And because it moves down, it's not pushing on the diaphragm as much. And so because you don't have all that pressure on the diaphragm, the mom is more easily able to expand her lungs. And so it's easier for her to breathe. The problem, though, is that as the baby's head moves down, you have more compression on the bladder. And so you're going to have some increased urinary frequency. You can also get some pelvic discomfort, genital area discomfort, because now the baby's head is so much closer to the cervical area and the pubic bones. And so you can get some pelvic discomfort during this time. So that's the expense, but the mom will often describe this as a positive thing because it's easier for her to breathe, even though she does have to go to the bathroom a little bit more. Some mild cramping, some mild lower extremity edema, and as mentioned, increased urinary frequency are all normal events during the third trimester. A lot of times we get worked up if we see edema. No need. Most of the edema, most women will have some edema during pregnancy. Most of this edema is going to be coming from the fact that the uterus, the gravid uterus, is compressing the vein, and so because you have that inferior vena cava being compressed, you're going to have a little bit of backflow in the veins, and so those hydrostatic forces are going to push fluid into the lower extremities. Now, if you see upper extremity edema or facial edema, that might be a little bit more concerning. So some mild lower extremity edema is nothing to get worked up about. If it's in the setting of hypertension, yeah, maybe be a little bit more worried. But just isolated mild lower extremity edema, totally normal. Some mild cramping, also normal. You may have Braxton Hicks contractions during this time, but just mild cramping that's not sharp or throbbing in nature, just a little bit of discomfort, totally normal. Complications during the third trimester. There's a lot. Okay, so you can have premature rupture of membranes. That can be preterm or it can be during the term period after 36, 37 weeks. Preterm labor and delivery for various reasons. Abruptio placenta. This is painful third trimester bleeding. Okay, abruption of the placenta. Placenta previa and vasa previa. Placenta previa being more common, this is going to be painless vaginal bleeding. Painless third trimester vaginal bleeding. Vasa previa is also going to be painless bleeding. The difference here, not only is their mechanism, but vasa previa, if you get bleeding from vasa previa, it's very ominous for the fetus because this is severe bleeding that's coming straight from the umbilical cord. So vasa previa is always going to be associated with some degree of fetal distress. Placenta previa, you can get a little bit of mild bleeding from that, really not so much associated with fetal distress unless it's severe. Preeclampsia, we already talked about that. That's one of the hypertensive disorders of pregnancy, quite common. Maternal complications include UTI, gestational anemia, and gestational diabetes. I meant to put these as subnotes to the maternal complications. But anyway, UTI, much more common during pregnancy than non-pregnancy. And the reason for this is because you have dilation of the ureters, you have some degree of urinary stasis. UTI should always be treated during pregnancy. And you have to bear in mind that if you don't treat them, many of them can lead to pyelonephritis, and that is a mess. So UTI, keep in mind, this is going to occur with greater frequency during pregnancy, and the further along you get in pregnancy, the more common UTI becomes. And then we already talked about gestational anemia and gestational diabetes. And not only are do these have an effect on the mother, but can also have an effect on baby, particularly gestational diabetes. You can get macrosomia, and then there's also supposed long-term problems for the baby. It can be associated with with lower IQ later in life, and it can also be associated with a predilection for obesity later in life too. Now these are the Leopold maneuvers. So this is the traditional way of assessing the fetal lie. The first maneuver is called the fundal grip, and what you're doing here is palpating the upper abdomen with both hands, and you're using the palms of your hands and fingers. And what you're feeling for is what's on the upper part of the uterus. So what you should feel is the baby's buttocks. You should not feel a head. If the head is up here, then you have a breech presentation, or at least the fetus is in breech position at that point. So you're palpating with your hands, and if you feel something hard or hard and round, then what you're probably feeling is the head. And you try to move it around, and if it moves independent of the trunk, then that is certainly a head. If you feel bony, irregular masses, that's probably shoulders. The buttocks should be soft and symmetric. Okay, so you shouldn't feel anything hard up here. The second maneuver here is known as the umbilical grip, and what you're feeling for here is the fetal spine. So you take your hands, you hold one hand in place, and you palpate with the opposite hand, and you're feeling for the fetal spine, which you can imagine what that feels like. And the fetal spine could be on either side, so it really just depends on what direction or what side the baby's lying on. So that's why you do it with both hands. And the spine should just be this sort of long, straight, maybe slightly curved projection of bony prominences. The third maneuver is called the first pelvic grip. So here you're taking one hand, you're feeling right above the pubic symphysis, using your thumbs and fingers, and that should validate your first maneuver. So here you should feel head. You should feel a hard prominence, should be somewhat symmetric, rounded off. And so here you're feeling for the head. And then the fourth maneuver is called the second pelvic grip, and here you're attempting to locate the fetal brow. So what you're going to do here is you're going to turn around the opposite side here, so you're going to be facing her feet, and you're going to stabilize the spine with one hand, and then move your hand down her uterus on the opposite side until you hit some resistance, and that is typically where the brow is. Okay, so you're getting an idea of how the fetus is lying. Leopold maneuvers, a lot have been really just replaced with ultrasounds because it's so much easier to see where the baby is laying than this Leopold maneuver, which really takes a lot of training to get really good at it. Okay, so these aren't done quite so much, but experienced OBGYNs will still use this from time to time. So patient education. We want to make sure that she's up to date on her vaccines. We always will give the Tdap vaccine in the third trimester, regardless of her previous vaccinations, because we will, by giving the vaccine, we cause another exposure, and that exposure will cause mom to make antibodies, and those antibodies can then be passed to baby. So we always give the Tdap vaccine, regardless of when the last time was that she received it. The influenza vaccine is given if it hasn't been given already, if it is the season. So if it's June, we're not going to give her the influenza vaccine. If it's November, we will. Hepatitis B, if there's no prior immunity. So remember back during the first trimester, we did that hepatitis B panel. If she doesn't have any immunity to hepatitis B, then we give the vaccine at that point. And you could probably do it earlier. You want to discuss the signs and symptoms of labor with her. So a lot of women will know what labor is, but this is particularly important for the prima gravidas. So spontaneous rupture of membranes, also known as my water broke, or if there's contractions every 5 to 8 minutes for an hour. Discuss symptoms requiring a prompt evaluation, i.e. when do I come in? Well, if there's signs of labor, if there's rupture of membranes, which is also kind of a sign of labor, if there's vaginal bleeding, that can be a sign of placenta previa, It can also be a sign of vasoprevia. It can also be a sign of abruptio placenta. So that is an indication to come in. If there's worsening edema, if there's headaches or visual changes, this can all be associated, is all associated with preeclampsia. And then the peripartum and postpartum considerations. So we want to know, where does she plan on delivering? Does she have a particular hospital in mind? Now would be a good time to do the tour of the hospital, of the labor and delivery ward, so she has an idea of what's going to happen. How is she going to deliver? Is it going to be a vaginal delivery? Is it going to be a C-section? Remember that if she has had more than one C-section, then we're always going to do C-sections thereafter. If she's had one C-section in the past, just one, then you can do a vaginal delivery, but there are some caveats with that. That's called a VBAC, vaginal birth after C-section. Now, the one exception to this is if her prior C-section was not the low transverse C-sections that we do traditionally these days, but was the up and down incision, then in that case, even if she's only had one, if she's had that vertical incision, in that case, we always have to do C-sections after that, and that's because of the risk of uterine rupture. So in this day and age, we do that fan and steel incision, where it's the low transverse, cutting from side to side, and that is conducive with a VBAC. You can do a VBAC after that as long as you've only done that C-section once. Okay? So hopefully I made that clear. If you have any questions, write me a note below. There are some people now that are saying that you can do VBACs after 2 C-sections, but that is not standard, and certainly ACOG has not validated that, but that has been thrown around in recent years. You want to know what her desire is for analgesia and anesthesia wishes. So does she want to have an epidural? Does she just want a spinal? Does she want to have nitrous? What does she want? How much anesthesia does she want? Some mothers don't want any. They want to experience the quote-unquote natural childbirth. Others are like, give me whatever you can give me that doesn't hurt the baby, because I don't want to feel any pain. Well, that's probably not going to happen, but there's going to be different preferences. Okay, so you want to discuss that with her. You also want to discuss breastfeeding with her. You don't need to go into too great of detail, because while she's in the hospital, you can, if she does want to breastfeed, you can set her up with a lactation consultant. But one of the things that we have found helps with breastfeeding is skin-to-skin contact after delivery. And so that is something to keep in mind if she does desire to breastfeed. Circumcision, if it's a boy, and then postpartum contraception. I don't think I've talked about this yet, but there is some contraceptive value to breastfeeding. Actually, I did talk about this in the gynecology section. There is some contraceptive value to breastfeeding, but it's not perfect. So you want to discuss that with her, that it doesn't take long after the pregnancy and she will be fertile again. We call those Irish twins. And you have one baby and then you get pregnant right away. And I have a pair of uncles that are only a year or two apart. Okay.